Many professionals were never taught how to fully assess tongue tie, and families are often left trying to reach their breastfeeding goals without the support they actually need. If feeding feels harder than it should, I don't want you to be alone. I wrote Tongue Tie for Parents to help you understand what's happening and how to move forward with a clear, thoughtful approach. It's the same guidance I would give you if you were sitting with me in my office. It takes a holistic, functional view, guiding you through what to look for, how to think about next steps, and what actually helps. Available now on Amazon. Link is in the show notes. Welcome to the season marking 4 years of the Tongue Tie Experts podcast. I'm incredibly grateful for what this space has become. What started as a simple idea to create thoughtful, evidence-based, and multidisciplinary conversations about tongue tie, infant feeding, and airway-centered care has grown into a global community of professionals who are committed to doing better for babies and families. Over the years, I've had the honor of sitting down with parents, lactation consultants, dentists, birth and medical professionals, therapists, researchers, and educators from around the world. Together, we've explored the science, the controversy, the clinical nuance, and the very real human stories that live at the heart of this work. My hope has always been that this podcast supports you in thinking critically, collaborating confidently, caring more deeply, and helping more people. If you're new here, welcome. I'm so grateful that you found us. To those of you who have been listening, sharing episodes, and sending messages over the years, thank you. Your support is the reason this podcast continues to grow. To our guests and sponsors, special thanks to you for your incredible contribution to this mission. Let's see how long we can keep this going. Please click, follow, leave a rating or review, and share with a colleague. It truly helps this podcast reach more who need to hear these insights. Now, let's get into today's episode. Hi, everyone, and welcome back to the Tongue Tie Experts podcast. I'm your host, Lisa Palladino, and I have a very special guest today, Dr. Sergio Suarez. Dr. Suarez is originally from Bogota, Colombia, but grew up in Hillside, New Jersey. He earned his undergraduate degree in exercise science and went on to receive his Doctor of Osteopathic Medicine degree from the Philadelphia College of Osteopathic Medicine. He completed his residency in family medicine at Mount Sinai, South Nassau in New York, followed by a fellowship in neuromuscular medicine and osteopathic manipulative medicine at Morristown Medical Center in New Jersey. Dr. Suarez is board certified, and this is pretty impressive, in family medicine, neuromuscular skeletal medicine, and osteopathic manipulative treatment. He has worked in primary care and sports medicine and now runs his own practice where he focuses on hands-on functional care, has led him into collaborating with providers supporting infants and families navigating feeding challenges, including tongue tie. In addition to his clinical work, he serves as an adjunct professor of osteopathic manipulative medicine at Touro College of Osteopathic Medicine. I'm really looking forward to this conversation because Dr. Suarez brings such an important perspective on how structure and function impact feeding and why this work is so much more than just what we see in the mouth. This is a key piece of the interdisciplinary care families truly need. So welcome, Dr. Suarez. I want to just add, you didn't put it in your bio, but you're a dad and a very hands-on dad, which is why it took us a little bit to get this interview together, but we're here. Thank you so much.
Yes. Hi, Lisa. Good morning. Thank you. And yeah, it's a challenge having a family life and work life. And my daughter was sick last week, so we had to reschedule. But thank you for being flexible and having me on as well.
Yeah, but I mean, that is one of the aspects of this work that we do, the family focused care, if we're being true to that paradigm, then our families come first, right? So I respect that immensely. And I think that's a great model to realize. And it's not just moms, it's also dads, right? Which is really, really
Absolutely. Yeah.
important as we evolve into a society that appreciates that need for moms and dads to be equally responsible for their children. But
Definitely.
so
Definitely.
thank you so much again for being here. And we are, I just want to disclose I am your patient, and I have learned a lot from you about my very own concerns and issues with my body. You've treated my grandchildren, and that may come into the conversation. But what I really want to start with is that you've had a lot of training and went in a lot of different related but different directions. And I'm just curious, like, what led you from focusing on primary care, sports medicine, into the work you're doing now?
Yeah, thank you. That's a great question. So I love sports, and we've also connected on this that we're both Mets fans, and
Mm-hmm.
baseball, basketball, football. Those have always been passions for me. Soccer as well. So I always and I liked taking care of people and the medical aspect. So I originally thought about sports medicine, and some of my earlier influences were orthopedic surgeons. So my original plan was I'm going to go to medical school. I'm going to do orthopedics. A lot of people go into medical school thinking that, and then you just go into different paths. But anyway, so I did exercise science, thinking about that sports medicine route, and then I did the pre med when I was in college, and that led me to eventually finding out about osteopathic education and DO school. I didn't know about DOs up until I was late in college. I was just thinking MD was the only way to get a medical degree. But yeah, I found out about DO school, and then that kind of just put it together that they also get the hands-on training where you're working with the body and you're using your hands to have an impact on people. And I was able to find a few mentors when I was in college, and then right after college, that actually did the osteopathic manipulation, which is a little bit rare. There's not a lot of people that actually practice it. So once I started getting a little more into that world, then I got a little more into the pediatric world and the pediatric aspect of osteopathy. And again, I was very lucky to have great mentors and teachers along the way that worked with a lot of kids and babies. And that's where I really found my passion is working with babies and families and moms and everything, and just seeing the impact that working on, for example, a newborn can have on the growth of that baby, and how they're gonna hopefully function better based on what we can help their structure in terms of getting things aligned and decompressed, and just working better after birth as well. So yeah, I just kind of went along with that, and I kept taking more continuing education courses and shadowing in different people's offices, and just kind of getting more experience, learning. When I went through my residency, which is a 3-year medical residency, basically in family medicine, I still was able to use my hands and use my osteopathic skills quite a bit, which was also great. And then I came back to New Jersey and did that fellowship year where I kind of brought it back together and did even more of that manipulative aspect as well.
Yeah, so
And
I
yeah,
yeah, I just want to
that's where
interrupt
I
you
am.
because I'm I know for a fact that most people don't understand the DO versus the MD and
Right.
the equal credibility of the DO with the MD. As far as you go through, that's a medical school education. It's just you come out with the
Right.
different initials. Can you explain that a little bit?
Yeah, yeah, of course. Yeah, and again, great question that we often often encounter. So, in the United States, there's basically 2 degrees where you have full medical rights, full practicing rights, prescribing, surgery. You can go into any specialty. So it's either MD or DO. So they are legally equivalent in the states. And the curriculum is very similar, so we go through and we have all, it's the same 4 years of medical training. Most of the schools still follow the model where you're doing 2 years in the classroom. The first 2 years are all pretty clinical, more science based, and then the third and fourth years are in the hospital, in the clinics. And really, we're mixed together. We're working with MD students in the hospitals, especially now that the residency systems have actually combined together. We're even more combined than ever, and that's great, because we get a lot of that, MD medical knowledge. However, the downside is that most DOs then end up not using their hands, and the manipulative piece, the manual medicine, which is, the origin of DO training. So yeah, I mean, you go through the same training as DO as MDs, except that especially in the first 2 years, we get added on. I think it's about 200 to 300 hours of hands-on training, just learning about palpation, diagnosis, and then some treatments as well, for the OMM, or the osteopathic manipulative medicine piece.
And
Also,
that is the to me the highlight and the important part that I wish so many DOs didn't drop. I do know
yeah,
a couple of DOs in my personal life who got into DO school, not MD school. And that was just like an aside, and they never even touched it after graduation, which is to me
yeah,
sad because,
right,
I
right,
believe in the power of, hands and healing. And um, yeah, it's just to me that's sad. But you know, you also, I know you train people. I actually was witness and privileged to be in the office one day when you had a student and you were explaining things to him, and that highlighted to me what was actually going on. Because if somebody asks me what exactly do you do, what I typical questions I get is it like a chiropractor? Is it
yeah,
like a this? Is it like that? And it's unique. So if you could just explain the mechanism a little bit, how can people relate to what you do? And it's a gentle hands-on treatment. There's no
sure,
cracking or, I can say that from my own experience. But
yeah.
what exactly are you doing physically with your hands that affects the body? I know that probably you could probably spend a week and a half telling me this, but in short form.
Yeah, yeah. So I think the way I think about it is, when you specialize in OMM, when you specialize in osteopathic manipulative medicine, I like to call it manual medicine, just because manipulative is just kind of a weird, uh,
Yeah.
a connotation, I guess. But anyway, OMM. Um, I think you're really, you have the medical knowledge, you have all the other things that you're taking into account, but you really become a specialist in palpation. So you really become attuned with being able to feel different strains and different things in the body. And this is something we actually teach in the medical schools, in the DO schools, from day one. We're taught to diagnose what we call TART, TART. So it's tissue texture changes, asymmetry, range of motion, and tenderness. That's the actual criteria. That's what the billing codes are based on. When you find any of those aspects, that's when you can diagnose somatic dysfunction. Somatic
Hmm.
dysfunction is the actual code that we are billing. That we're making that diagnosis is because there's somatic dysfunction in the neck or in the head or in the spine, the pelvis, whatever it might be.
Hmm.
So through all our training and through all of these hundreds of hours of spending time with other mentors and classes, we're fine tuning our hands to be able to pick up on these different things throughout the body. So we're
Hmm.
picking up on strains, on things, and the whole idea is structure and function, right? Like if there is
Hmm.
some restriction, some impediment in the structure, then the function is not as good. it's compromised. So, we're able to use our hands to find those areas, which I think is the most important part, the diagnosis.
Mm-hmm.
Anybody can kind of go around and touch and, and work, and, that probably has some benefit too, just the hands-on aspect. But being able to actually diagnose that, it's this specific suture in the head, or it's this rotation in the pelvis or in the sacrum, whatever it might be, that clues us into what the body actually needs to be able to heal.
Right.
Which is another principle, is that the body has a self-healing mechanism, and we tap into that, with our hands. So we're
Mm-hmm.
able to diagnose, find where the restrictions are, and then basically, like you said, very gently, with very gentle maneuvers, very gentle balancing techniques and things like that, kick in the body's self-healing mechanism. Sometimes we are trained in what we call high velocity, which is like the cracking techniques. So
Mm-hmm.
that is something that we do learn earlier on, but I use it very sparingly, and
Mm-hmm.
it has to be like, where something feels really stuck and it feels like it needs a little extra force or something for me to do that. And we definitely don't do that with babies. Babies don't
Right.
get the cracking at all. So
Right. And that would
it's,
be something just to align things so that things can flow and heal
yeah,
again.
exactly,
Yeah.
exactly. If there's a vertebrae that's very rotated or out of
Yeah.
alignment, then you might have to actually give it a little bit of a nudge to go
Mm-hmm.
back
And
in place.
I'm just going to speak from my own experience and to my audience about nobody's got more stress and strain in their body than I do. I have a history of musculoskeletal problems, and I haven't needed a cracking from Dr. Suarez. And the most that I feel is a tenderness, sometimes a little deeper tenderness or stronger tenderness, never pain, except in pain that's already there in my body. So
Right,
so
right,
this is amazing that you're explaining it like this. And I just want to start relating this to how this relates to infants and tongue tie. And the connection, as we talk about so often on this podcast and in all of my work, the connection between the structure and the function, and why just looking isn't enough. So
right, right.
let's talk about that a little bit. What do you see
Sure.
in tongue-tied babies, or how do explain why your work can help a baby who has oral restrictions? Have you ever found yourself thinking, do I actually know enough about tongue tie to assess this baby, to talk to this family, to know what should happen next? If you've ever had these thoughts, our newest program, The Confident IBCLC, was created with you in mind. And it's open to anyone who works with babies and families. You don't have to be an IBCLC. This is a 1-hour live, low-cost, high-impact training for anyone working with babies and families who wants more clarity, stronger clinical reasoning, and more confidence around tongue tie and feeding concerns. This masterclass is here to quiet that imposter syndrome that's been whispering in your ear, and to remind you that you are capable, qualified, and needed. You can sign up right now at tonguetieexperts.net. The direct link will be in the show notes.
So yeah, I mean, I think the main way that the osteopathic work supports the tongue tied or tongue tied babies is, the frenulum itself is a piece of fascia, right? So the frenulum is part of I think it's the deep anterior fascia that then extends down the rest of the body, down to the leg, all the way down to the um, like adductor muscles down in the inner part of the leg through the diaphragm. So it really is a whole body connection, right? So when I get babies that are usually referred by a lactation consultant or a feeding specialist, somebody that knows a little bit about DOs and osteopathic medicine, and they think that it can help support them. I'll do my full assessment. I'll do the full assessment for the whole body, see how things are feeling, and then also, I'll go inside and actually see how tight the tongue tie is, the frenulum, how like restrictive it might be. And the thing with the osteopathic treatment, especially the cranial treatment, is that we're opening up a lot of the cranial base. So the cranial base for anyone, but for babies, speaking about babies right now, the cranial nerves that come out of the cranial base are what actually move the tongue. Those are
Mm-hmm.
the glossopharyngeal nerve, hypoglossal nerve that are coming out of those little foramen of their little skulls, and that's what's actually moving the tongue. So like even if it's a very like to the tip and very restricted down frenulum that obviously needs to get released, if it's not getting the proper nerve function and blood flow, it's just not going to work as well as it can. So
Mm-hmm.
in a way, we're optimizing the release as well, the frenectomy, by opening up all of the nerve and blood supply and getting things moving as well as they can before the release. And then, so I usually recommend at least one, maybe two, a couple of treatments before doing a release, and then definitely a treatment after the release as well, because something else happens after the release where I think the treatment is helpful in terms of like it's almost like smoothing out the rest of that fascia. Sometimes what I'll feel is, the baby gets the tongue clipped, and then it's almost like a little bit of restriction or like some tension in the sternum or like in other parts where that fascia maybe just needs a little bit of help to kind of get a little more balanced, and other parts of the body as well. And also like with many procedures, there's a certain stress on the body from the procedure itself. A lot of times you
Mm-hmm.
come out of surgery and people can't poop, right? You get like
Mm-hmm.
post-op ileus because your body just went into that fight or flight. Sometimes, not always, but sometimes babies get that feeling as well. And I feel like, the osteopathic treatment just kind of helps to balance that. And if they're not moving right after the procedure, or, for some reason they're not latching again, which is rare, it's not always the case, but sometimes this can help to get some of that
Yeah.
back as
So I speak a lot about how the release is not, first of all, it's not the whole thing. It's not, treatment does not always equal release. And release in isolation usually doesn't solve the problem. And this is a very scientific and medical way to explain why this is true. And you are validating my idea of we can release the tongue, but if there's tightness around, and I use very very non-specific terms. I talk about feeling tightness in the body, and my hands have become very intuitive over the years of using them as a nurse and a mother
yeah.
and a midwife, and you have to have a lot of sensation
And
and use of
grandma now.
and a grandma, yeah. So the I've always felt, or especially in later years, been able to feel that there's a tension pattern in the baby, not having a technical way to treat that or to name it, but knowing that that need is there. And you are describing for me, it's like light bulbs going off in exactly what I feel in my hands, but don't have the education or the training to do anything about. And that's why we need teams. Like, this is a beautiful conversation.
Yeah.
And we can go into the conversation about my very own youngest. Well, let's talk about my second grandchild, and I won't name any names, but the one that you saw this week,
Yes.
who did have treatment before her releases,
Right.
had treatment after, did lovely. Like, she really did well. Aside from a little bump the night of the release, which is expected, she
Hmm.
did so much better, and better than the previous baby who had not as much treatment before the release. Let's just say that.
Yeah.
So she did well, but then she started sliding back, and life happened, and my daughter didn't have time to do anything, but she had a lot of things going on. She had multiple clogged ducts. She had a lot of pain. The baby has constipation. And I just kept saying, you have to go back to Dr. Suarez. And she's like, I'll get there, Mom. I will. So she finally comes back to you.
Yeah.
And the day after her treatment, well, that night even, or even in your office when she nursed, she said, Mom, I could feel a difference right away. She was she was opening her mouth better, her tongue was lifting better, there was no pain, and she hasn't had a clogged duct since then. And you told her to give her 3 days to start pooping regularly. The next
Yeah.
day, she was at my house and she had this explosive bowel movement. And she has been going every day, sometimes more than once a day, since that. So,
Right.
this is a first on one, N of one, but I've heard other stories and I have other examples, of patients I've sent to you that this is real. It seems like you're not doing that much. It honestly, I have to be honest. It seems like what's he doing? He's putting his hands here and there. But it really, really, truly works. And the difference in these little babies, especially, is incredible. So thank you for your skills. Thank you for what you do.
Oh, thank you for referring and trusting as well. I mean, and yeah, I mean that's a great example. And just to make a comment about that, it happens pretty often, because um, babies are doing well, like she gets in a good groove, and then a lot of times when I think this happens a lot when there's a growth spurt or there's a
Mm-hmm.
big, like those leaps, like developmental leaps and things like that. Sometimes those old tension patterns kind of come back.
Mm-hmm.
And I guess, it's kind of like even in an adult, like you could be feeling really good for a couple of months. And then, over time, your body just compensates until bam, you get a neck
Right.
strain again or something.
Right.
And then you have to go back for like a maintenance treatment, so
Right.
it's a similar concept. And especially in the first year of life, there's so much going on with babies. They're growing so fast, their brains are developing so fast. I mean, they're hitting all these milestones and things like that. And I usually tell patients like all right, let's get the acute issue under control. Whether it's feeding or torticollis or reflux, whatever it might be. Let's get that better. The sessions might be a little bit closer together in that sense. Um, and then after that, I always tell them what I recommend is bringing the baby back in around the pediatrician schedule. So
Mm-hmm.
if it's like, a 4 month visit, a 6 month visit, a 9 month visit, those are made for a reason, because that's when those babies are hitting a lot of those milestones
Mm-hmm.
and developing. So I think it's a good idea to align that with an osteopathic treatment along, sometime around that as well, just to kind of keep things balanced and moving well and everything. And yeah, like you mentioned with your granddaughter, she had developed. It'd been a few months, I think, since I'd seen her, and there had developed some more tension, and her little head and her neck were tight again. So once we released a lot of that and got a lot of those areas open again, she was able to latch better again and poop better. And yeah, things just kind of clicked
Yeah.
again, and hopefully, she'll be good for a little while again, and she won't need it, for hopefully another few weeks or maybe even a month or so as well.
Yeah. And thinking back, so many major milestones happened in her little body in that time between the
Right.
treatments.
Right.
So it's
Exactly.
understandable.
Yeah.
Yeah. So, and then there's the idea, there are a lot of people who believe that um, we're releasing too many tongue ties, and some of them can just be, you know, I don't know, treated away with body work. And
Mhm.
I'm curious as to how you feel about that, because I used to think that if I saw a frenum and there was dysfunction, it should be released immediately.
Yeah.
This is going back, right? So I admit to that. So if anybody sees any past, 15-year-old posts that I made or blogs that I wrote, that might have been what I was saying. But I've since evolved in my thinking as the research has come out and we see um, more about how body work and multidisciplinary treatment leads to better outcomes, and how if there are no symptoms, we shouldn't be proactively doing any surgery. That just doesn't make sense. So,
Right.
what are your thoughts on there are some frenum that we see that appear to be tight and may not need to be released, or do they need to be released? Or can
Yeah.
body work just do it all?
So I mean, I don't think that body work or osteopathic work can do it all. I agree that there are certain instances where um, one of the, the tight frenulum might be the driving factor in the baby's dysfunction. And I like to tell parents, let's look at the function. Let's see how the function is going. um, if the baby, and this is where like working with a lactation consultant also is very helpful, because you guys can do like a weighted feed for me, and we can see, is the baby actually transferring.
Mm-hmm.
If that baby can transfer, then that shows me, okay, then there's some, it's something is working, something is
Right. And transferring comfort for mom is a big clue too.
Yeah, right, exactly. Or yeah, or like, is there pain for mom?
Mm-hmm.
What are the symptoms? What's the function for both, for the dyad, right? For mom and baby, how are things going? Um, if there's zero issues, then there's always the question of, oh, is it just because mom has such a good supply that like she's
Right.
overcompensating, and the baby
Right.
doesn't really have to feed, doesn't have to work the mechanics, because the milk is just getting shot into their mouth. So
Mm-hmm.
that's one thing there. So you really have to look at, like, I feel like you have to look at the individual case. Every baby, every dyad is different.
Right.
But
And
I feel like,
the whole picture, right?
yeah,
That's
exactly, the
yeah,
whole
yeah.
picture. And I think you have to, usually what I recommend is, let's do like at least one or two of these treatments, the osteopathic treatments. Let's see how things go. And sometimes people tell me like, oh, look, the pain with the lash is gone, the baby's feeding great, things are much better after a couple of treatments. So then, we take a step back and be like, okay, look, so maybe, there is some form of frenulum restriction there. Do you guys want to do a procedure or not? I think that's at that point, I think I kind of leave it up to the parents. I'm like, look,
Mm-hmm.
there's not as many symptoms now. The baby's doing well. Could there be things in the future? I mean, potentially. I think, there's not a whole lot of strong research. Correct me if I'm wrong, but
Right.
right now, I think stuff is coming out in terms of like facial development and airway
Yeah.
development and all that
Right.
stuff. But I think right now the research that we have is mainly on breastfeeding, on nursing, right?
Mm-hmm.
Like if
The
there's
other
dysfunction.
thing, the one thing that is really interesting and evolving is the research are looking into if baby, if there's a frenum there and the function is breastfeeding, if baby is breastfeeding well, using their tongue efficiently, using all their musculature the way it should be, that should in itself help to develop the face and the airway. So it's
Right.
not so much about the frenum, but about how the baby is actually using it. Are they compensating? As you talked
Yeah.
about, like that drinking from the water fountain kind of nursing,
Yeah.
or are they choking and gagging, but they're still gaining weight? Are they refluxing because they're getting so much, but they're giving some back? Are
Right.
they uncomfortable? Are they having explosive bowel movements? So, all those things are important. That I think that sometimes families think that there are no symptoms when if you go down the list of possible symptoms, there are,
Yeah.
that families aren't recognizing. But if there truly are no symptoms and everything's fine, then everything's fine, because we actually don't have any research. We don't have good research that shows that fixing a tongue tie or doing surgical release on a tongue tie is going to do anything in the future, which is kind of
Yeah.
scary,
Yeah.
but
Right.
you
Right.
know, it's the truth,
And some parents decide to do it because of those future outcomes.
Right.
They've seen something, and they're, oh, it's going to affect the speech, or it's going to
Yeah,
affect.
even though we don't have the proof of that.
Right, right,
Yeah.
and it's not always the case.
Yeah.
I have one family I'm working with right now, and they're kind of like right now on the fence about whether or not to do it. And the mom is like, "Look, I have a giant tongue tie, and like I had no issues. I had
Mhm.
speech was fine, no neck tension or whatever,
Right.
anything else." So I'm like, you can't argue with that. It's like, it's
Right. Sometimes
not.
I like to say I would ask that mom, "Do you snore?" Because there's those
Yeah,
downstream issues that we don't really know, we
that's
don't connect,
there are
But I
other
had a
things.
family one day and they came into the office, and the dad was being treated for sleep apnea, and he was in his early 30s, and he was already on a CPAP machine and had severe sleep apnea, and they had found out that it could be related to his tongue tie. And they were starting the journey from the father's perspective, which was
Yeah.
interesting because you don't usually
Yeah.
get this with a young family. And
Right.
that's why they wanted to have the baby checked. And sure enough, the baby did have a significant tie. And we did everything. And the baby, they're like, the baby's already sleeping with his mouth open. Like, okay, don't worry. We'll get this. We'll get this. But
Right. So you're
now,
picking up on
let's
those
talk
red
about
flags.
being on the fence, right?
Yeah.
So my youngest granddaughter, who's now like 10 weeks old, when I was allowed to examine her, because I always restrain myself and just be a grandma for the first couple of days, but when I was allowed to look under her tongue, I didn't see a prominent frenum, and I was very excited. It's not even a posterior hidden
Hmm.
in the beginning anyway.
Yeah.
She did
Yeah.
look like she had a very small mouth, meaning her lip was tight and her maybe buckles, I'm not sure, but she did amazing. No pain from mom, gained appropriately, no problems, no symptoms. I sent her to you when I started to see a little bit of dysfunction in the manner that she nurses. She's
Yeah.
not opening, she's sliding on off the breast sometimes, and she's a little fussier than a baby her age should be, which is
Right.
another thing that families don't recognize, especially if it's first time baby. Like, no,
Yeah.
she shouldn't be crying that much in the afternoon. We there's something's going on there. So she came to you, got some relief. Do you want to talk about your point of view on that side? I hate to put you on the spot, but like
Uh,
what if you
yeah.
want
Yeah.
to just
Sure.
give a little bit of what
And
I
I
know
think,
you
if I remember correctly, I think she did have a little bit of pain. I think she did have some nursing pain when she
just
came.
sometimes, she said, just
Yeah.
sometimes
Yeah.
on one side. And that was dismissed. Like, oh, it's not a big deal. She's very laid back. That's not a big deal.
Yeah, yeah,
Yeah.
but I think that did improve. I think it did get better.
Yes.
Yeah, so we've
Yes.
kind of been working with her, um, and right. I mean, I think if anything, I agree. Like, you didn't really see much under the tongue in terms of like restriction, but her upper lip was very more clearly restricted. It seemed
Yeah.
like. Um, so then there's that question. Like, could it be not just the tongue, but it could be like an upper lip issue?
Mm-hmm.
And I think that could very well impact the feeding and the tension in the body and all of that as
Mm-hmm.
well. I've actually been in an office with one of the providers that does the releases, and I was fortunate enough that one of my patients was actually going in that day to get released, and I asked him if it was okay if I just palpated while he did the release.
Mm-hmm.
And I remember palpating this baby, this back of her head. And as he was releasing it, and it's so quick, it's like a couple
Yeah.
seconds and they're done. But it was when he released the upper lip that I actually felt like that occipital bone just really let go and released.
Wow.
So I think even, there's fascia that we don't even understand, like, the
Yeah.
connections that are going on. And from that day that I felt that, I was like, wow, I mean, even that upper lip can really impact
Mm-hmm.
what's going on in the rest of the body as well.
Yeah.
So yeah, I mean, I think with her, and I've even said, like, I would probably, if you're, if you're on the fence and you're thinking about doing a release and you think that you might end up doing this when the baby is older or whatever, it probably is just better to do it when they're younger anyway, when they're
Mm-hmm.
babies, just because of the recovery. And you're already getting up with them at nighttime, so if you need to go in there and stretch and do all that stuff, you're already kind of in the middle of it. Try doing that with a toddler; it's going to be a nightmare.
Right. Right.
So, or an older kid. So I think
Plus,
in that
don't you
sense,
believe that the longer the body is compensating or having those restrictions, pulling on things, the more tension is there for longer? Is that harmful?
it can. I mean, I think it's hard to say, right? I mean, I think
Uh huh.
it's if it is a very restrictive tie, or it could, yeah, it could definitely pull in some other things and cause, like we were saying, causing like the airway to develop.
Mm-hmm.
um the narrow palate, the narrow
Mm-hmm.
airway could be a possibility for sure. But I mean, in on the flip side of it, I think sometimes some people grow and don't have much of an issue, right? I mean, even if there is, I think that's why it's so hard to gauge, like, how restrictive the tie is, or how much of a problem it really is. Because
Mm-hmm.
even if it's like to the tip, but the tongue is moving and they're functioning, how do you gauge, okay, that one, okay, maybe because they can't move it at all, but for some reason the breastfeeding is working. Somehow it's working. But yeah, I mean, the body compensates in different ways.
I have witnessed oral restrictions to the tip of the tongue, and that tip of the tongue can't move, but the back can lift. So the function isn't as impaired as
Right.
some mid position or posterior tongue ties. So that's interesting. So again, goes into the realm of you can't tell by looking at it.
Yeah,
We
but
definitely
then
can't tell by looking at it.
with that tip of the tongue tie, then okay, so then the back of the tongue is moving, and so they're able to get the nursing. But is that the kid that's going to have trouble with speech because
Right,
they're not going to be able to make those sounds and make,
right.
they're going to end up in speech therapy and getting a
Yeah,
release when they're toddlers. So it's hard, and I think this is what's so hard for parents is that a lot of times they're put into this gray zone where they're like, the pediatrician is like, oh no, the baby's gaining weight, the baby looks great, don't do anything about it, it's fine. And then on the other side, they're going to have people telling them like, look, it's the tongue tie, you got to get it done. So they're getting pulled from both ends. And usually, with me, I end up kind of telling them the thing about, let's look at the function, let's look at how the whole picture is looking, what's going on, is even after a couple of these treatments, is there still a problem? Maybe then the tie is more restrictive than we think. So I think, at least for right now, with what we have to work with research and data, I mean, I think that's kind of what I like to
yeah,
use as the best approach, and not jump to doing it, like, just from looking at it right away, but also not just totally blowing it off and be like, okay, this is just not anything real, and
right,
not
right,
not going that direction either.
right. So this is a perfect segue into my new book, and I shameless plug, but education is key. Yeah, and my latest book, which came out on Amazon yesterday, is Tongue Tie for Parents, and it's all
Congratulations.
about education because it's up to the parents. And I think the more we educate and empower parents to make informed decisions, that's going to lead to better outcomes and happier families and less tension in families if they understand the whole issue and understand that it's in their power, and it's up to them to make this decision, and that no professional knows more than they know about their own baby, especially the mom, right?
Absolutely, yeah,
Yeah,
mom's
and
instincts.
your whole approach and outlook on that is why I consider you part of my team now, and I'm thrilled to be able to refer patients to you and share care of patients. And what I would love to talk about is you're in New Jersey, and I would love for your practice to explode. But where else and how else can people find people like you in other parts of the country or the world? How do we
Yeah.
find Dr. Suarez's who are doing manual therapies like you are in other places?
Yeah, and this is one of the reasons why I still teach at the medical school, because we need to get more people doing this. We need to get, show young medical students that this is a real specialty, and that they don't have to lose their osteopathic skills because they want to go into internal medicine or anesthesia, or whatever it might be. I mean, that's fine too, but I think we definitely need to grow this. It's a medical subspecialty.
Mm-hmm.
It's OMM. It's osteopathic manipulative medicine. One of my mentors used to joke around and call us OMMtologist. It's
Mm-hmm.
an OMMtologist. There's a couple of good resources. So one place I would start is, yeah, it's basically the like kind of like the national governing body for osteopathic cranial manipulation. And
Mm-hmm.
anyone that's doing this, especially working with babies, should have extensive training in cranial manipulation. That's one of the big things that we look at. So that organization is called the Osteopathic Cranial Academy.
Okay.
And you can actually go on their website, and they have like a search for a provider
Okay, great.
function.
And I'll link that in the show notes so people can find it.
Yeah, and unfortunately, I for some reason I'm not on that website yet, even though I have extensive training. But it's just
Right.
it's been I haven't been able to follow up on why they haven't put me on there. But anyway,
Okay.
but most providers that are like have the cranial training should be there. So that's probably the main place I would go with. Um, there's a couple of other sites. I mean, I guess the AAO is the American Academy of Osteopathy.
Okay.
That's basically like the governing body for
Mm-hmm.
manual medicine, for
Okay.
osteopathic manual medicine as well. So the American Academy of Osteopathy, the Osteopathic Cranial Academy, and then there's another group that's like basically like a subset of cranial osteopathy. That's biodynamic osteopathy.
Okay.
So that I'd have to I might have to send you the link for that, but I think
Okay.
it's traditional osteopathy, something like that is the name, and they also have like a search for a provider function
Excellent.
there
And
as well.
that's the official way to find trained providers, which I would check out after. My way always of finding good providers is Facebook groups,
Yeah,
local
yeah,
Facebook groups of what I don't know. I don't know if it's an insult to still say the word crunchy mom groups, the moms or breastfeeding groups or,
yeah, yeah,
look inside there. And the other thing is that if you know a good dentist who is doing frenotomy, you can ask them because if they're a good dentist doing frenotomy, they network with other providers.
yes,
So
yeah, definitely.
they like if I asked Dr. Siegel for a reference for a DO, he would give me your name. So that's how you would find in your local area someone like Dr. Suarez who is doing similar things. And hopefully this pool of providers will grow because there's definitely a need for it. This I add this on the list of different types of manual therapists. I like to give parents an educated choice of who to use. So I give them the chiropractors I know that are good. I have a couple of different craniosacral providers, speech language pathologists when there's more oral motor need there. So, all of this is part of the hands-on PTs. I don't want to leave out my PT OT friends. I'm trying to think of who else I don't want to insult anybody. Very multidisciplinary. And I think that as a lactation consultant, it's important, especially in the climate that we practice in with the under the microscope care that tongue tie is right now, we have to be careful not to not to say, oh, your baby needs to go to this other doctor. You have to give them
Mhm.
a choice. So if you're a
Yeah,
lactation consultant, find your team, find a choice of team members. You may prefer one over the other, but it's up to parents to make that decision because otherwise we get accused of nasty things. Which never happens. We don't kick back to each other, right, Dr. Suarez?
oh no, definitely not. No, we just want the best outcomes for the families.
Excellent. And
That's
that's why I'm so happy and grateful that you're on my team and grateful for the time that you spent with me this morning. This was a great conversation. I am sure my listeners will enjoy it immensely. Thank you so much. And what's the best way for people to actually get in touch with you? And we'll list it in the show notes as well. Do you have a website?
Yeah, I have a website. Yeah, so my website is the name of my practice is Suarez Osteopathic Medicine.
Okay.
So the website is www.suarezosteopathic.com.
Okay, great.
Um, I, yeah, I think it's Suarez Osteopathic, not
All right,
Suarez.
I'll definitely get the right link in the show notes.
I'm pretty sure it's suarezosteopathic.com.
Okay. All right. So,
My phone number, email, all of that is on there if anyone wants to get in touch.
excellent. So thank you so much again and have a wonderful day. This podcast is meant for education and conversation only. It is not medical advice and does not replace formal education, professional training, or individualized care from a qualified healthcare provider. Always seek appropriate guidance for individual concerns. The views and opinions shared by our guests are their own and do not necessarily reflect those of the host or tongue tie experts. Many professionals were never taught how to fully assess tongue tie, and families are often left trying to reach their breastfeeding goals without the support they actually need. If feeding feels harder than it should, I don't want you to be alone. I wrote Tongue Tie for Parents to help you understand what's happening and how to move forward with a clear, thoughtful approach. It's the same guidance I would give you if you were sitting with me in my office. It takes a holistic, functional view, guiding you through what to look for, how to think about next steps, and what actually helps. Available now on Amazon. Link is in the show notes.